Key takeaways include the fact that MDS, even though we characterize it as one disease, is actually very heterogeneous, and it's very important to consider the patient in front of us, what their risk is, to be able to fashion the appropriate treatment strategy. That allogeneic stem cell transplant, although it's the only way to cure the disease, we do need to be very mindful of how we select patients so that we can ensure that the benefits, in fact, in any one patient outweigh the potential risks. And finally, we learned about new promising approaches, which are still quite preliminary, that target a specific molecular pathway in MDS. I think MDS is one of those diseases where that is incredibly important, really being able to lean into understanding what the disease is all about. So the goals of treatment in MDS vary depending on whether the MDS is considered lower risk versus higher risk. Lower risk MDS patients, some of the major concerns include the need for red blood cell transfusions, and so treatments are often selected in terms of their ability to improve that and improve quality of life. Lower risk MDS patients are less likely to have their disease transform to an acute myeloid leukemia. And so we bear that in mind when we're selecting therapy. Patients who have higher risk MDS, on the other hand, the risk of transformation to an acute myeloid leukemia is higher. Their disease is often characterized by mutations that contribute to a shorter survival. And so the treatments that we select are tailored accordingly. And they're treatments that are designed to try, if possible, to prevent transformation to acute leukemia and that have the potential to prolong overall survival. In thinking about treatment of higher risk patients with MDS, it is very important at the outset to also factor in whether such patients are good candidates to be able to benefit from an allogeneic stem cell transplant, or commonly known as a bone marrow transplant. Over the last decade, we have made significant advances in our understanding of the different gene mutations and molecular pathways that contribute to MDS. We believe that the next few years, we hope, will bring new approaches that effectively target some of those pathways and mutations. Already, we have one drug that is specifically targeted to a particular kind of mutation, the IDH1 mutation, which was approved by the FDA a couple years ago. And in our session today, we talked about approaches to target splicing factor mutations, which are one of the more abundant types of mutations that we find in MDS, and that cut across both the lower risk MDS and higher risk MDS. So we're very excited about that. Those trials are still preliminary, still very early on, but we hope that this is an area that can be built upon. Another very important area of research, which we believe will inform the next set of clinical trials and approaches for the future, is the ability to drill down in every one of the clinical trials in which our patients are enrolled, to actually see what's happening to these mutations that I have talked about. This is something that we don't often do routinely, and in our session there was quite a lot of talk about how we can work together collaboratively, including both physicians, scientists, people in regulatory aspects of clinical trial development, such as the National Cancer Institute and the Food and Drug Administration, how we can all get together to be able to really learn the most from the clinical trials that our patients have so graciously volunteered, their time and, their efforts for. So it is my sincere hope that these different approaches and efforts will yield fruit in the coming years. I look forward to being able to report upon that.